Hello and welcome to Journal Club today. So today we've got Olga who's going to present for us, and she's going to be presenting about dexamethasone in hospitalized patients with COVID-19. So I'll let you, I'll hand over to her there, okay?
Hello and welcome to this week's Journal Club. My name is Olga. I'm one of the IMT trainees, and today I'm going to talk about the use of dexamethasone in hospitalized patients with COVID-19. And I have to mention that this is the preliminary report and it's an article review for Northampton ICU Journal Club. So I hope you enjoy it. So first of all, we are all in the middle of a pandemic now, which is caused by the SARS-CoV-2, which was first identified in China in December 2019. We do know that most cases of COVID-19 infections are asymptomatic or mildly symptomatic. However, there is quite a high number of patients that can develop a serious respiratory illness, which will require a hospital admission. And this respiratory illness could ultimately lead to hypoxic respiratory failure, which could require prolonged ventilation, which could be, of course, invasive or non-invasive. Case fatality among all patients with COVID-19 in the hospitals in UK at the time of this report was about 26%. However, case fatality was 37% among UK patients undergoing invasive mechanical ventilation. So what makes COVID-19 so serious? Well, this infection can cause an acute pneumonic process with diffuse alveolar damage, inflammatory infiltrate, and microvascular thrombosis. And this could happen in the most severe COVID-19 cases. It can also lead to inflammatory organ injury, which can be seen in blood tests through inflammatory markers, which are highly increased. These inflammatory markers are CRP, ferritin, interleukin-1, and interleukin-6. So why are we thinking about using glucocorticoids for COVID-19 patients? Well, first of all, there is this theory that the host immune response has an important role in other viral pneumonias, such as MERS or even seasonal influenza. And there was a widely debated role of glucosteroids as well, because at the time when the pandemic started, no one was really sure whether or not they could be used or not. And even some guidelines would contraindicate or not recommend glucosteroid use at all. And there was also an absence of reliable evidence or a large-scale randomized clinical trials. And as I mentioned earlier, some hospitals were using steroids for treatment of COVID-19 patients, while others were contraindicate them. So, moving forward, the aim of this study, which is called the recovery trial, was to evaluate the potential effects of potential treatments in patients hospitalized with COVID-19 infection at 176 NHS organizations in the UK. What kind of methods have we used to do this? So first of all, we want to know which patients were eligible for this trial. So eligibility criteria included hospitalized patients with clinically suspected or lab-confirmed COVID-19 infection. These patients had to have no other medical history that can put them at potential risk if they were to participate in this trial. There were also a limit of age, which was removed on the 9th of May 2020. This limit was 18 years old. And at the beginning, pregnant or breastfeeding women were not eligible to be enrolled. However, they became eligible afterwards. So in terms of method, there was a randomization which was based on the baseline data collection. This was done using web-based case report form, which included demographic data, also level of respiratory support, so invasive, non-invasive ventilation, or just oxygen, or just nothing. Also major coexisting illness, suitability of the trial treatment, and also other treatment available at the trial site. The web-based system was used with concealment of the trial group assignment. I also need to mention that eligible patients assigned were in a ratio of 2:1 to receive either the standard care alone or the usual standard care plus oral or IV dexamethasone, which was in a dose of 6 milligrams once a day, IV or oral, for a maximum of 10 days or until hospital discharge or other suitable treatments in the trial. There was a single follow-up form when patients were discharged or had died, or at 28 days after randomization, whichever occurs first. The outcome measure, the primary outcome that we wanted to look at was the all-cause mortality within 28 days of randomization. There was a secondary outcome as well, which was the time until discharge from the hospital, or other subsequent receipt of invasive ventilation or death. There were other pre-specified outcomes such as cause-specific mortality, hemodialysis, major cardiac arrhythmias, duration of ventilation, or whether or not they have actually received ventilation at all. So for statistical analysis, recruitment was close to the dexamethasone group on the 8th of June 2020, when there were enrolled more than 2,000 patients. So based on the primary calculation and the ratio of 2:1, there was a minimum number of 2,000 patients that needed to be randomized to dexamethasone and 4,000 patients that needed to be randomized to just treatment alone. So for the primary outcome, there was a hazard ratio from Koch's regression, which was used to estimate mortality rate ratio. Kaplan-Meier survival curves were constructed to show cumulative mortality over 28 days period. And then we had Koch's regression, which was used to analyze secondary outcome of hospital discharge within 28 days, and the log binomial regression model, which was used to estimate risk ratios. And in this chart, you can see that the median age of the patient was about 66.9. And because there was a difference in age between patients that were randomized to dexamethasone and patients that were randomized to usual care, there was a specific distribution of patients which they were distributed in less than 70 years old, between 70 and 79 years old, and more than 8 years old. And as you can see, about 64% were men and 36% were women. And further down, you can see the number of patients that received no oxygen, oxygen only, or invasive mechanical ventilation. Moving forward, the pre-specified analysis of the primary outcomes were performed in 5 subgroups: age, sex, level of respiratory supports, days since symptom onset, and predicted 28 days mortality risk, and all analysis performed according to intention to treat principle. So if we go back here, we can see the age of them, as I mentioned earlier: female, male, sex, median number of days since symptom onset, which was 8 for dexamethasone and 9 usual care, median number of days since hospitalization, 2 and 2 again, oxygen, non-oxygen, and so on. In terms of results, we are looking at 11,303 patients that were recruited for this study, and 1,948 of these patients were excluded because of the site not having the dexamethasone available, or they were not suitable for randomization to dexamethasone. The remaining 9,355 patients underwent randomization between dexamethasone and other treatments. And out of these ones, 6,425 received randomization between dexamethasone and usual care alone. As you can see in this diagram, 2,104 were assigned to receive dexamethasone. And out of this number, 1,975 actually received dexamethasone, so 95%. And then out of these, there was a second randomization, and then 2,104 were included in 28-day intention to treat analysis. Right. Moving forward, this chart shows us the respiratory support at randomization. And we can see that we had quite a significant number of patients that were receiving invasive mechanical ventilation and oxygen as well. Fewer were receiving no oxygen. And
Sorry, continue.
okay. Then if we look at this table, we can see the results, primary and secondary outcomes. And we are looking at mortality at 28 days as the primary outcome, as I mentioned earlier. And we are looking at the secondary outcomes, which is discharge from the hospital within 28 days, invasive ventilation or death, invasive mechanical ventilation, and death. And we'll come back to this in a bit. Looking at this chart, we can tell that there was a significant number of patients who benefited from dexamethasone, as it was shown to reduce the number of patients that died within 28 days, and also had a favorable outcome in patients who received invasive mechanical ventilation. Also, preliminary results showed that, as I mentioned earlier, use of dexamethasone for up to 10 days resulted in a lower 28 days mortality than usual care patients. In patients receiving invasive mechanical ventilation and those receiving oxygen without mechanical ventilation at randomization. There was also clear benefit in patients treated for more than 7 days after symptom onset. And the reason why is because it is thought that the primary pathophysiological mechanism of organ injury is actually the inflammation, which is caused by COVID-19 after 7 days of symptom onset. And from these results, we can see that there is no evidence of benefit for patients not receiving respiratory support at randomization. You can have a look again. Right, so invasive ventilation, oxygen only, no oxygen. Um, 15% of all hospitalized patients with COVID-19 in the UK were enrolled in this trial. Only essential data were collected at the hospital sites, with additional information being accessed through linkage with routine data sources. And preliminary results were published on June 16 and adopted into UK practice since. And this is the reference which I viewed, the recovery collaborative group, dexamethasone in hospitalized patients with COVID-19. Thank you, and let me know if you have any questions for me.
Thank you, Olga, for that great presentation. So I'll leave it open to the floor to see if anyone wants to have any questions. You can unmute yourself. Do you want to just say?
Any question? So what dose of dexamethasone do they recommend?
6 milligrams IV once a day or oral for up to 10 days or until.
What's the oral for what was the oral dose?
It was 6 milligrams.
So it's the same as the IV dose?
IV or oral, same dose.
Okay. What's the bioavailability of that drug then? If you're giving exactly the same, so are you assuming the dose of whether they give it intravenous or oral is the same?
That's a good question. They haven't mentioned this in the study, and I think it's a good question to be raised because it might vary then.
Do you want to ask anything?
No.
So with recovery trials, so how many arms are there now then? How far along? Because there are quite a few versions of it now, isn't it? That's true. This first version was published on June 16. So I think we are ongoing with this randomization to dexamethasone and further randomization secondary to other treatments. So I'm not sure about the results for the other sort of treatment in regard with the recovery trial at this point.
Yeah.
Sorry?
Sorry.
Okay.
Not good currently. Maybe on HG?
Do you have any questions?
So the paper.
No, unfortunately, I was managing the newest patient and just joined in. But yeah, I hope to see that presentation. It would be good if it was. Can it be uploaded?
Yeah, they do upload it on.
Brilliant. Yeah, thank you.
I'm not sure if the paper gives an answer, but does it talk about hydrocortisone as vasopressor sparing in the same way as we'd see in sepsis, or does it talk about the pathophysiology in terms of suppressing the cytokine storm? What does the paper write-up actually talk about in terms of pathophysiology?
Right. Any other questions?
No. No. Thank you very much. Well done.
Right. Thank you so much.
Thank you.
Bye.
Bye.